Assalamu alaikum everyone. My name is Noor Waseem and today Assalamu alaikum everyone. My name is Noor Waseem and today I'll be giving the lecture on hormonal changes in parturition and lactation. It's short compared to the previous lecture and it's very interesting. Trust me, it's really interesting. So if you have any question, please feel free to reach out to me using my phone number or email. I'll be more than happy to help you guys. Okay. So parturition is basically birth, the process of birth, childbirth. Lactation is basically milk production. Okay. Okay. So maternal endocrine changes during pregnancy. So we have changes in four main organs, which is basically the pituitary, thyroid, adrenal gland, and liver. What happens to pituitary? Pituitary gland basically enlarges due to lactotroph hypertrophy and hyperplasia. Why? Because prolactin is being produced during pregnancy. And because of that, there is enlargement because lactotrophic cells or the lactotrophs are enlarged. This is stimulated by estrogen. And when there is enlargement of pituitary, that might slightly compress on the optic chiasm and there can be visual problems and then the person can become dizzy, right? It's not exactly bitemporal hemianopsia, but it's also completely different. Okay, so don't confuse this with that. It enlarges, so there can be dizziness and visual problems when it's pressed against the optic chiasm. One main thing I want you guys to remember here is now because the pituitary is now swollen, so what happens, it's more prone to vascular insult and necrosis. What do I mean by that? So during pregnancy, during labor, when the mother, she loses a lot of blood, what happens is that when that huge amount of blood is lost, this pituitary, the swollen pituitary, like I said, it's very susceptible to vascular insult and necrosis that can undergo ischemia. Okay, the pituitary gland might not get enough blood supply because of hemorrhage or the increased blood loss. There is necrosis of pituitary gland, and this is called Sheehan syndrome. High yield, very high yield. Okay, you guys can get an SEQ on this, so keep this in mind. All right, so the next thing that we're going to do is that we're going to talk about thyroid. What happens to thyroid? Again, thyroid is increased, the sizing is increased because T3 is increased, production of T4 is increased, and again, this happens under the influence of estrogen, and it increases thyroxine binding globulin, which binds to more T3 and T4, and because more T3 and T4 is being produced and then later being binded to TBG, thyroid gland also increases. Okay, the next one that we have is adrenal gland. What happens in adrenal gland? In adrenal gland, the estrogen, they stimulate the liver production of cortisol binding globulin. Later in pregnancy, serum free cortisol levels rise at parturition. In my previous lecture, I just said that remember, cortisol is very, remember one word when you hear cortisol, it's just stress, increased stress in the body, and that basically increases at like the end of pregnancy or at the late pregnancy. Now, the cortisol is increasing, the body is in stress towards the end of pregnancy, and the body is now preparing to push the baby outside. At the same time, that cortisol will not disturb or will not have an impact on the baby. Why? Because even though cortisol is something that produces stress within the mother's body, the baby is protected because that cortisol is converted to an inactive form of cortisone in the baby so that it's free or it's protected from the impact of stress. Okay, the next one that we have is liver. Estrogen stimulates liver angiotensinogen and renal renin, which increases angiotensinogen 2 and aldosterone. Remember, aldosterone, it reabsorbs sodium, so you're going to increase the water retention in the body. Okay, and so there is increased volume expansion in the mother or the pregnant woman. Okay, one important thing that I want you guys to note here: everything happens because of estrogen. Stimulated by estrogen, estrogen induced, estrogen stimulates. So the changes that happens in all of these organs is under the influence of estrogen. Okay, so talking about the next one, which is maternal physiological changes during pregnancy. Okay, so decreases TPR. In pregnancy, the main hormone that is produced is progesterone. Like I said, that progesterone is responsible for maintaining the pregnant state of the uterus. Progesterone is also responsible for keeping the body calm. It's responsible for keeping the myometrium calm, and like it prevents contraction, right? So because it keeps the internal system relaxed, right? So it dilates the blood vessels as well. Okay. Now, because the blood vessel or the teeny tiny arterioles, venules are dilated, it decreases the total peripheral resistance in them, and it increases the body volume. Okay. Because obviously there is more water retention due to aldosterone, more sodium is absorbed, and the body volume increases. Now, early in pregnancy, there is an effect which is increased stroke volume in the heart. Very simple. Like I said, cardiac output is stroke volume into heart rate. So of course, stroke volume is going to increase. So this happens in early pregnancy. In late pregnancy, there's increased heart rate. Of course, because cardiac output is high, both of them are high, so heart rate increases, but that's towards the later pregnancy. Also, the spiral arteries transform, which decreases the peripheral resistance. Now, bring the thought of progesterone. Progesterone helps in keeping the myometrium of the body calm, so that decreases the resistance within the vessels. TPR is reduced with the total peripheral resistance, and again, the spiral arteries they transform, and that also the what do you call, the resistance within the arteries is reduced. Okay, total body volume increases, and it goes up to 8 liter, where normal is around 4 to 5 liters due to water retention. And because of that, mild bloating or edema can occur because water is being retained in the body, and the number of RBCs it increases. Okay, clinical box, important. Let me read. Because the growing uterus exerts pressure on the veins of the leg where they enter the abdomen. Now, the growing uterus, okay, now the uterus is growing, and now it's pushing on the veins of the legs. What happens? There is increased pressure, and that pressure is transmitted upward towards the thorax, okay, or the abdominal region. So the pressure comes upwards. Even though there is more pressure towards the veins of the leg, there is also increased pressure upwards. And you know how we have the inferior vena cava within the thoracic region. So if that inferior vena cava is compressed, in this case, it can be dangerous. So what happens? Venous pressure in the lower extremities rise on standing. So when the mother stands, there's increased pressure in the lower extremities or the legs. Like I just said, that growing uterus, it pushes on the veins of the legs, right? So there's an increased venous pressure. And because of that increased venous pressure, there is going to be edema and venous damage within the lower extremities. Okay, that is why when often in pregnant women, we do have swelling of their legs or their feet. Okay, and this is the reason, because the venous pressure in the lower extremities is increased, and edema occurs. So lying down in the supine position can result in compression of the inferior vena cava by the uterus. So, you know, when you're lying down, I said that when there's increased pressure due to the fetus in the lower extremities, that pressure is transmitted upward to the thorax, and we have the inferior vena cava in here. So because of that, when a woman lies down, there are chances that her inferior vena cava can be compressed, and in that case, that leads to maternal hypertension. Okay, so remember this point of maternal hypertension. So it's an important clinical box. Okay, talking about the respiratory system, what happens here? It looks complicated with all the CVP material here, but inshallah, I'll make it easy for you guys. During pregnancy, functional residual capacity and residual volume, it increases. Now, what does this mean? Now, it means that during pregnancy, the amount of air that is left in the lungs after a normal breath, which is the FRC, fetal functional residual capacity, and the air that remains after the deepest breath, which is basically the residual volume, is decreased. Okay, so again, FRC is the amount of air that is left in the lung after you breathe normally, and the residual volume is the amount of air that's left in the lung after the deepest breath you have. Okay, the deepest breath that you take. So both decreases. Why? Now that is like, think about it. The growing uterus, it pushes up against the diaphragm. And when it pushes up against the diaphragm, it leaves no space. It leaves no space for the lungs to expand. So by this way, the body compensates by breathing at the same rate to maintain the oxygen levels. To simplify, the uterus is growing, it pushes over the diaphragm, and now the lungs will try to like help the person exhale maximum air so that there's left air left inside. As a result, both function residual volume capacity and residual volume decreases. The respiratory rate remains constant, which means the number of breaths taken per minute, they're obviously going to be constant regardless of pregnancy or not. Minute volume and tidal volume, they rise. Okay, so what is minute volume? Minute volume is basically the total amount of air that is breathed in 1 minute, and tidal volume is the total amount of air that is breathed with each normal breath. Okay, like breathe in and out with each normal breath is basically the tidal volume. And the minute volume, it is the total amount of air that is breathed out in 1 minute. That increases. Now, why it increases? That is because the body needs more oxygen, like both for both the mother and the growing fetus, and because of that, both the minute and the tidal volume increases. At the end, they say it also lowers the PCO2, means that the level of carbon dioxide that is in the body or in the blood is decreased. And it is a good thing, right? You're having a growing fetus, you'll try to give in more and more oxygen and less carbon dioxide. So when minute volume and tidal volume are increased, which means more and more oxygen is taken in with each breath, so PCO2, more and more PCO2 is expelled with each breath. Okay, so it's kind of working with a lower PCO2 is kind of working with increased minute volume and tidal volume. So more oxygen taken in means more and more carbon dioxide being removed, and that's a good thing. Okay, so next one. Let's go to the renal changes. Are there any questions? No. Okay, now talking about the renal changes here, there is increased GFR. Okay, that increases by 60%. Simply put, in simple words, the kidneys are working more and more harder in order to cause the filtration. And because now there is more stress on the kidney, there is increased GFR, and that is going to increase the amount of glucose and amino acid that is expelled in the urine. Okay, so which will increase in glucose urea and amino acid urea. And also there is increased level of deoxycortisone and aldosterone, which stimulates the renal salt and water retention. We know that they're involved in retaining water. So when water is retained, like I said, there is an increase in the body volume. Okay, and then there can be edema as well. Talking about GI, of course, now you're having a fetus, right? There's a growing baby, so there will be increased intra-abdominal pressure, which causes increased intragastric pressure, or like pressure within the stomach, and that can cause acid reflux. How does it cause acid reflux? Is because there is that main hormone called progesterone. It decreases the lower esophageal sphincter tone. Lower esophageal sphincter is somewhere here. Okay, and progesterone, it decreases the tone. What happens? It's now the lower esophageal sphincter would easily open, and there would be acid reflux. Okay, increasing acid reflux, and the person would experience something which is called a heartburn. Okay, all right. Talking about the last one, which is diabetogenicity of pregnancy. Pregnancy induces insulin resistance and hyperinsulinemia. Now, when you're talking about this, let's go back to the previous lecture, which I just explained, that a hormone called HPL, it decreases mother's response to insulin. So what happens? Now the mother is insulin resistant, and more insulin is being produced, even though the mother's glucose is not responding to that insulin. So what happens? There is going to be hyperinsulinemia, increased insulin in the blood. And the next point was that HPL hormone, it basically increased lipolysis. Now, because although HPL is depriving mother of the glucose, or is not letting the mother use the insulin, it tells the mother, oh, you still got to use something. So I would help you, or I would allow you to undergo lipolysis, which is basically usage of free fatty acids, usage or breakdown of free fatty acids. So what happens is in this context, the maternal metabolism is favored towards fat usage, and that reduces the peripheral insulin response. Okay, sorry about that. And that induces the peripheral insulin response. When that insulin response is decreased, just a minute. When that insulin response is decreased towards the free fatty acids or towards the lipolytic process, what happens, regardless of body using free fatty acids, still there is increased insulin levels. Just give me, I'm sorry about that. Zara, can you pause the recording? Okay, so talking about this again briefly. So their pregnancy induces insulin resistance and hyperinsulinemia. Now, because of the HPL hormone, the mother's body is not responding to insulin, and there's increased production of insulin that results in hyperinsulinemia. So what happens? HPL says to the mother, oh, how about you use free fatty acids, right? So mom's metabolism shifts to free fatty acids, and even on free fatty acids, insulin does not have an effect. Regardless of that effect, there is still increased amount of insulin being produced that results in increased pancreatic insulin secretion and beta cell hyperplasia, right? Beta cells are the cells of the pancreas that are involved in secreting insulin, and when more and more insulin is secreted, the size of the beta cells increases, okay? And if diabetes is resolved post-delivery, it is called gestational diabetes, okay? Talking about parturition, parturition basically means childbirth, and it lasts like an average, sorry, human pregnancy lasts an average of 40 weeks. And what happens in parturition? There are 3 steps. There is strong uterine contractions, there is delivery of the fetus, which takes less than an hour, and then the last step is delivery of the placenta along with contractions of the myometrium. Okay, important stuff. Parturition, placental, sorry, it's supposed to be 1A. Parturition, placental CRH, and fetal adrenal axis. Okay, so I tried to add an easy picture here. What happens? This is the placenta. Placenta would secrete a hormone called corticotropin releasing hormone. When that happens, placental CRH, it would stimulate the fetal ACTH secretion. Okay, CRH goes to the fetus. This would increase the fetal ACTH secretion. And what happens? Cortisol is produced. Remember, I told that cortisol is basically the stress hormone. And because cortisol is produced, it would come back from the fetus and it would increase CRH again. Okay, so there is like a positive feedback loop here. As in, when CRH increases, it goes to the fetal adrenal gland, and then it secretes something which is called the cortisol, and cortisol comes back and it increases CRH again. So there is a continuous increase, which is now called the positive feedback loop, and you can see with the plus over here. So this CRH, which is produced here, which comes back to the placenta from the fetus, it now goes to the myometrium, and it makes the myometrium sensitive to prostaglandin and oxytocin. Remember, prostaglandin and oxytocin are 2 very important things that are involved in the initiation of labor or in the contraction of the myometrium. Okay, so just to briefly do that again, so the placenta produces CRH. Okay, now this placental CRH, it will stimulate the fetal ACTH secretion, which would cause the production of cortisol, and then cortisol would come back as CRH in the placenta. Now this CRH would go to the myometrium and it would increase the production of prostaglandin and corticotropin releasing, prostaglandin and oxytocin, which is involved in the initiation of labor, and now the baby can be delivered. Okay, next one, the link between estrogen and oxytocin. Remember, oxytocin has some major functions. One, that it is involved in uterine contraction. The second one is there is initiation and progression of labor. The third one is that there is milk ejection. The fourth one is that it helps in the mother and baby's bonding. Okay, so it has these four main functions. Just keep this in mind. What happens? What does estrogen do during parturition or during the process of childbirth? Now, estrogen, it amplifies the receptor and responsiveness of the myometrium to oxytocin. Remember, I told that oxytocin, just now I told the functions of oxytocin, of which one of it is increasing uterine contractions to push the baby out. When that happens, when the oxytocin receptors are being sensitized by estrogen, there's increase in prostaglandin, and prostaglandin is also involved in the progression of labor. So oxytocin, it releases the oxytocin release occurs in response to cervical stretching. When the cervix is being stretched, it means the baby is ready to come out. Labor is being initiated, so it initiates uterine contraction during childbirth. Okay, so you can get a question that which of the following is which of the following initiates uterine contraction during childbirth, and one of the option could be cervical stretching, and that would be the answer. Okay, and this happens under the influence of oxytocin. Cervical stretching, it initiates a positive feedback loop that initiates to the progression of labor, like I just said, and oxytocin is employed to induce labor. All what we are like talking about is oxytocin, prostaglandin, and inducing labor. And this process starts with estrogen. So high doses of prostaglandin, such as PGF2 alpha and PGE2, are used to enhance uterine contraction. Okay, so if I was to tell you this in the form of a graph or in the form of a flow chart, it would be placenta. It basically secretes something called estriol, which is a form of estrogen. So what happens? It makes the receptors of myometrium more sensitive to oxytocin, and then oxytocin comes and promotes uterine contractions. Okay, this was a picture that was there in Dr. Abdul Jabbar's slide. Placenta secretes estrogen. Estrogen sensitizes the oxytocin receptors. What happened? There is oxytocin-induced uterine contractions now. Also, at the same time, there is stretch of cervix. It initiates a positive feedback loop, and it goes to the posterior pituitary, which releases oxytocin. And oxytocin and estrogen, like from both of these directions, there is increase in uterine contractions. There is increased stretch of cervix, and hence a positive feedback loop is generated here. Okay, so because when there is labor being initiated, there should be increased oxytocin and prostaglandin. So more the oxytocin, the better, because then the baby is being pushed out and the mom can be free as quick as possible. Okay, so that is why a positive feedback loop is being generated between oxytocin-induced uterine contraction and neuroendocrine loop. Okay, this is the neuroendocrine loop. Okay, you guys can read this, important. Mammogenesis and lactation. It talks about the mammary glands having approximately 20 lobes, each containing excretory lactiferous ducts that open at the nipple. I'm sure Dr. Ani, I guess, or whoever is teaching histology must have covered the histology of the breast, which is very important. One thing I need you guys to remember here is that there are myoepithelial cells that contract upon oxytocin stimulation. Remember a while ago, I just mentioned that one of the function of oxytocin is basically milk ejection or expulsion. So oxytocin helps the myoepithelial cells to contract, and then milk expulsion, and so the baby can breastfeed and have milk. Okay, so hormonal regulation of the mammary gland development. Estrogen has three important functions when it comes to the development of mammary glands. It promotes ductal growth and branching. It stimulates the accumulation of adipose tissue, and it directly influences breast development, and it indirectly stimulates the maternal pituitary prolactin produced by the lactotropes. Okay, the prolactin is also important here. All right, so let's go ahead. You guys can just read this. This was an easy part. Coming to the one of the main topic, which is basically lactogenesis, which is the production of milk. Now, after giving birth, Now, the first milk that is produced, and it's highly antimicrobial and anti-inflammatory, is called colostrum, and it's very good thing for the baby. A decrease in placental progesterone level at parturition triggers breast milk production. Remember how progesterone was continuously increasing throughout pregnancy, and once labor is initiated and the baby is delivered, now progesterone would obviously decrease, right? Because now you no longer need to maintain the pregnant state. So this would basically cause the breast milk production. So decreased progesterone causes breast milk production. The next point says that lactogenesis and the maintenance of milk production, which is galactopoiesis, it relies on stimulation by prolactin. Prolactin is also involved in stimulating the development of milk, okay, and the maintenance of milk production. So prolactin is involved here. Prolactin release during the nursing period is stimulated by suckling. So when the baby suckles or when the baby is being breastfed, what happens? Dopamine secretion is inhibited. Remember how dopamine inhibits prolactin, and if dopamine is not inhibited, there will be more and more and if the dopamine is not inhibited, there will be more and more prolactin production. So this is what it's talking about here, right? So here the dopamine secretion is inhibited, and because of that, there is prolactin increase. Okay. All right. This is basically all what I spoke about. Here we have the posterior pituitary. Here we have the anterior pituitary. And in the posterior pituitary, once we have increased oxytocin production, that is going to cause the concentration or the contraction of myoepithelial cells. And that's going to cause the milk letdown reflex. We'll talk about that. At the same time, when there is decreased dopamine, because dopamine inhibits prolactin usually, but if dopamine is inhibited, there will be increased prolactin production, and when there is increased prolactin production, like it said here, it helps in lactogenesis, which is maintenance and production of milk. Okay, so dopamine decreased, so it goes to the lactotroph cells, and those cells which are involved in secreting prolactin is increased. That causes galactopoiesis, production and maintenance of milk. Again, milk down reflex. Okay, so oxytocin and prolactin are mainly involved here. And then the baby, when he suckles at the nipple, what happens that there is a positive feedback towards the posterior anterior pituitary, and then there is increased prolactin. You see the increased prolactin, again this reaction happens. Also oxytocin, remember I said that it's involved in milk ejection. So when the baby suckles, that causes increase in oxytocin. This is also a positive feedback reflex, just like how this was. And because of this, there's increased oxytocin, contraction of myoepithelial cell, milk down reflex, and suckling at nipple. Another important thing that I need you guys to remember is when during milk production or lactogenesis, when there is increased prolactin, so that more milk is produced for the baby. Another thing that happens here is there is a negative feedback on GnRH. GnRH is gonadotropin releasing hormone, and this hormone generally is involved in producing LH and FSH. Remember, LH is basically involved in ovulation. When there's an LH surge, there is ovulation, and FSH, it is involved in development of follicles. But what happens when there is a decreased GnRH? If there is decreased GnRH, there is decreased LH and FSH. What happens? There is lactational amenorrhea. Means that while breastfeeding or during breastfeeding, the mother is no longer having her menstrual cycles, right? Why? Because increase in prolactin because of milk production decreases GnRH, decrease in GnRH decreases LH and FSH, means low FSH, no development of follicles, low LH, no ovulation. So no ovulation, no menstruation, and during that period, the mother undergoes something which is called lactational amenorrhea. So the mother is not having her menstrual cycles, and hence she cannot get pregnant. Okay. Coming here, lactational amenorrhea and let down reflex. Prolactin suppresses the release of gonadotropin releasing hormone, like I just mentioned in the previous slide, that leads to lactational amenorrhea, a natural contraceptive effect that may help space out pregnancies. Although it's a contraceptive effect, but it's not like it's not 100% efficient. As in, for that to happen, a mother needs to a mother needs to breastfeed her child regularly, like 24 hours a day, day and night, in order to have lactational amenorrhea, and then that would have a contraceptive effect. Otherwise, the mother can get pregnant, or the mothers will be having her regular cycles. Okay, it is not considered as effective, like I just mentioned. Suckling at the nipple, it triggers a neuroendocrine reflex, stimulating the release of oxytocin from the posterior pituitary gland, just mentioned, and psychogenic stimuli, such as the sound of the baby crying or thoughts about the baby. It's very interesting, like when a mom delivers her child and when the baby cries, even though she hears a baby that's not crying, or she hears a baby on TV or somewhere, she will still have the release of oxytocin, because she's having that connection with the baby, and that induces oxytocin release, and that initiates the milk letdown reflex, which is basically the production of milk, and now the milk is then moved to the ducts of the breast, and the baby can now drink milk. That's called the milk down reflex. Okay, menopause. It's basically when the menstrual period within the women stops. Typically happens around age 52, and happens when ovaries run out of functional follicles. You know how we had like 400,000 follicles before birth, and then that decreased to 300,000, and like it decreased and decreased, and then eventually a female girl's body has around 410 follicles, and then she has those periods until the age of 52, and like each one follicle is being released every month, and she's having her normal cycles. Okay, in menopause, at around age 52, the female body has run out of follicles, and she's no longer having her periods, so that's called menopause. Now, this results in decreased estradiol levels. Why estradiol levels? Estradiol is also a form of estrogen, because the ovaries have lost their ability to form estrogen or to produce estrogen, estradiol, or progesterone, because there are no more follicles over there, and there is an increased level of follicle stimulating hormone and LH, causing secondary amenorrhea. In case you're wondering what primary amenorrhea is, primary amenorrhea is basically when a girl never gets her period, like never, like a growing girl in her childbearing age never gets her period. That's primary. Secondary is the menopause, when the period stops during menopause. Okay. Also, let me come here. What did I mean by this point? This one, sorry. There is a decreased estradiol levels and increased level of follicle stimulating hormones. So basically, when a woman is fertile and when she's having her normal cycles and she's having her normal menstruation every month, right? So one follicle is released from the ovary every month, right? So because of that, the follicles or the ovaries, they are involved in production of estrogen and progesterone. Now, when she's no longer having follicles during the menopause stage, what happens? There is no production of estrogen and progesterone, because she does not have follicles to produce them. There is a negative feedback. Usually, in normal cases, there is a negative feedback to the hypothalamus, which causes GnRH, and as a result, there is increased FSH and LH. Okay, now because she does not have estrogen and progesterone, there is increased production of FSH and LH, and this is why in a woman who is undergoing menopause, she will have increased level of these two hormones. Okay, so there is no feedback inhibition in this case. So a woman's lifetime exposure to estrogen increases the risk of breast and endometrial cancer. Now, estrogen and progesterone, they're basically trophic hormones. What do I mean by that? It means that they make the cells grow. Estrogen, we can get it, a woman can get it through placenta, she can get it through ovaries, okay, while she's she's undergoing menstruation. So that increase in estrogen during her lifetime is a risk factor of breast and endometrial cancer. Okay, so a normal woman having normal periods is at high risk of having breast and endometrial cancers, along with other risks such as early menarche, late menopause, nulliparity, which means not having kids at all, and breastfeeding. These are the risks associated. Menopausal symptoms include palpitation, joint pain, decreased libido, vaginal dryness, sleep disturbances, and these are some of the symptoms which include irritability as well. However, some women, they might also take estrogen hormone replacement therapy, which is a hormonal replacement therapy, which can help decrease the menopausal symptoms, these symptoms. But again, you're giving her estrogen once again, so she's at increased risk of breast and endometrial cancers. Okay, so coming here, the menopause, the years, and the hormones involved here. Okay, so FSH FSH is increasing. Okay, menopause occurs at around 51, 52, let's say. Before that, FSH is increasing because there is development of follicles, right? LH is also increasing. Okay, slowly by slowly. However, estradiol, when there are follicles, estradiol is being produced at menopause. At menopause, what happens? The body runs, or the ovaries run out of follicles, so no estradiol being produced. So estradiol decreases. Now, like I said, that when estrogen and progesterone decreases, there is feedback inhibition, and as a result, the levels of FSH and LH increase. Just exactly here, you don't have estrogen and progesterone. What happens? There is no negative feedback inhibition, and then FSH and LH will increase. They would increase and increase and increase because the body now thinks that, oh, I'm not producing estrogen and progesterone. How about I try to increase my production of FSH and LH during menopause in an attempt to increase the levels of estrogen and progesterone. But since she's at menopause and she's lost her follicles, FSH and LH decreasing, despite them increasing, there is no effect on estrogen and progesterone. So that is why after menopause, there is increased FSH, there's increased LH, okay, and decreased estradiol levels. These are some some contraceptive methods. You guys can read this. The barrier methods, spermicide, sterilization, intrauterine device. It's pretty simple. Just go through the explanation. And yeah, let's talk about our second last slide, which is twins. Now we have dizygotic twins and we have monozygotic twins. Dizygotic twins, by the name, di, it means two, right? So it basically means there are two eggs released at the same time, and there are two sperms that are fertilizing these two eggs. Okay, and all of these stages happens, and then we basically have dizygotic or fraternal twins. Okay, and they will have two separate amniotic sacs, two separate placentas, two separate chorions, and of course two zygotes. Normally, in normal pregnancies, which is having one baby, like we just spoke about it in the last lecture, one sperm, one egg, fertilization, formation of morula, formation of blastocyst, implantation, and then there's one baby, one amniotic fluid around the endometrium. That is basically normal. However, in monozygotic or identical twins, there are certain things that you need to remember. If during the pregnancy, let's say there's fertilization and one egg has fused with one sperm, and now it's at the two-cell stage. It divides, undergoes mitosis, and it's at the two-cell stage. If now at the two-cell stage, this cell divides twice. Look, it has it's been divided twice, right? So it's gonna form two identical babies with separate placenta. Okay, this one, you see two identical babies and they both have separate placenta. Okay, if this mitosis occurs twice at the morula stage, okay, so what happens? There is monozygotic twins. There is one common placenta here you see, and then there is one common placenta. All right, and this happens at the morula stage. The next one that we have is when it's formed at the blastocyst. When the mitosis occurs twice at the blastocyst stage, it undergoes division, and now both of them have one amnion. You see, there's just one amnion. Here they had two amnions. Here they had two amnions. Okay, and here they had one placenta, and here they're having like two placenta separately. Yeah, and they're having one amnion. Okay, however, if the division or if mitosis occurs at this stage, formed embryonic this stage, this would basically result in conjoined twins here. Okay, you see the babies are conjoined here because it's a little bit too late when the mitosis occurred twice, and this results in conjunctions. And after surgeries, in some cases, the babies can be separated or else they cannot be. Okay. Talking about monozygotic twins, they arise from one fertilized egg, one egg plus one sperm that splits in early pregnancy. Okay, it can either split in the two cell stage. When it happens, then there are two identical babies, and then there's separate placenta. Here at the morula stage, when they're splitting, they're going to have a common placenta here, but they're going to have their own amnion, and they're monozygotic twins. If it occurs at the level of blastocyst, and then these babies will be having one amnion and of course a common placenta, like we can see. If it happens at the later stage, which is after the formation of the amniotic cavity or the amniotic fluid, this basically results in conjunctions. Okay. Finally, we're at our last slide. This is something called the Apgar score, and this is usually calculated as soon as the baby is born, typically between first and fifth minute. So what happens is you look at the appearance of the baby and you give them score. If the baby is pink, you give them 2. If it's blue, you give them 1. If the baby is pale or blue, you give them a score of 0. Okay. And you check the pulse and you see which pulse is being corresponded to the score, to the table here, right? And then you give them scores accordingly. Again, goes to grimace, which is basically crying, and like their facial expressions, you calculate them and you put the score. A is for activity, R is for respiration. If the Apgar score is more than 7, it means the baby is normal. If it is less than 7, it means the baby requires further evaluation. If this score remains low at the first minute and the 5th minute continuously, it means the child has high risk of developing long-term neurological damage. Okay. All right. We're having checkpoints, so I would recommend you guys to pause, answer, and then go to the explanation. Okay, the first question says, which of the following could inhibit the initiation of labor? Administration of an antagonist of the actions of progesterone, administration of LH, administration of antagonist of PGE2 effects, and mechanically dilating and stimulating the cervix, administration of oxytocin. You guys can pause, think of the answer, and now I will go to the explanation. So the explanation here is C, administration of an antagonist of PGE2 effects. They're asking inhibits initiation of labor, right? It inhibits labor. Remember how in the previous slides I mentioned that oxytocin and prostaglandin E2 and PG2 alpha, PG2F alpha are very important in uterine contraction and initiation of labor. So if you antagonize them, that would prevent the progress of labor. Okay, so the correct answer is C, because it says administration of antagonist of PGE2 effect. Okay, talking about the first one, administration of antagonist of action of progesterone. So progesterone is basically involved in maintaining pregnancy. If you give an antagonist of progesterone, okay, it will stop the maintenance of pregnancy, but it would not lead you or stop labor. Okay. Next one is administration of LH. You don't need LH because LH is involved in ovulation and release of the egg, right? So you don't need that right now during pregnancy. C is correct. Mechanically dilating and stimulating cervix, which is also involved in increasing the oxytocin levels, and that is involved in the initiation of labor. Administration of oxytocin, no. If you give oxytocin, the mother would directly progress to labor, right? So we need something to inhibit the labor, and it is antagonist of PGE2 effects. You can read this explanation. Next question. During the first few years of after menopause, FSH levels are normally extremely high. A 56-year-old woman completed menopause 3 years ago. However, she's found to have low levels of FSH in her blood. What is the best explanation for her finding? Why is she having low levels of FSH in her blood? Option A, she has been receiving hormonal replacement therapy with estrogen and progesterone since she completed menopause. Option B is her adrenal glands continue to produce estrogen. Option C, her ovaries continue to secrete estrogen. D, she took birth control pills for 20 years before menopause. Okay, so the best answer here is A. Remember how I told when you give them hormonal replacement therapy, especially when women, they would take estrogen. So there will be increased estrogen now, right? So when there is increased estrogen, there is feedback inhibition initiated. Okay, so feedback inhibition initiated, so that would decrease FSH and LH, and that is exactly her case, low levels of FSH. Her adrenal glands continue to produce estrogen? No, not at all, because she is after menopause now. Her ovaries continue to secrete estrogen? No. She took birth control pills for 20 years before menopause? No, not at all. That is not involved in decreasing the levels of FSH. The explanation is here. The next question, a 30-year-old woman is breastfeeding her infant. During suckling, which hormonal response is expected in the woman? Okay, here are the options. Think of the answer, and I'll go to the next explanation next. The answer is increased secretion of oxytocin from paraventricular nuclei. Now, she's breastfeeding her infant, right? So the infant is suckling, right, during breastfeeding. This would have a positive effect on the paracellular neurons, which basically increases the prolactin level. It decreases the dopamine level that allows the meltdown reflex. At the same time, breastfeeding means baby suckling. It also goes and increases oxytocin, and that contracts the myoepithelial lift reflex. Contracts the myoepithelial cells, and that causes the meltdown reflex. Now, the option that makes sense out of all of this is increased secretion of oxytocin. Exactly, because that is what I just mentioned. And remember when I told one of the functions of oxytocin is basically the ejection of milk. And when the baby is suckling, that kinds of gives a positive feedback response here. Increase in oxytocin, increase contraction of the cells, and there's milk letdown reflex. Okay, and you can read the other option. ADH is not involved, ADH is not involved, and neurophysin is not involved here. Increased plasma level of ADH and oxytocin, again, ADH is not involved at all. So yeah, the answer is C. Last question, what causes menopause? And pretty simple question. The answer is D. Of course, reduced number of follicles available in the ovary for stimulation by gonadotropic hormones. So that's it. That's pretty much it. You guys can read the questions here, and we're done with our second session. Alhamdulillah. And please, if you have any question, feel free to text me, to message me, or email me. I would be more than happy to help you guys. And drop in your feedback, please. Let me know how I did. And thank you so much, Zahir Sayed, for hosting both my sessions, this session and the previous ones. And remember all of us in your du'as. And I really hope and pray that all the first years have good endo-repro exam, second years with neuro, and third years with GIT, us. So yeah, inshallah, best of luck, guys. I hope everything goes well. And this break is more than enough for you guys to learn for exam and ace this exam. So thank you very much once again, everyone, for listening to my recording. And thank you, Zahra.